Kita ba ang slides?
Yes.
Opo.
Okay. Mag-i-interaction tayo ha. Okay lang? Sinabihan ba kayo ni Miss Anne? Mini-mini mo ako kung sinong tawagan ko. I mean, sino yung ipo-point ko. Okay ba kayo dyan or hindi?
Okay, Doc.
O walang kung yung tawagan ko. All right. So this is the same, and this is just a continuation. I'd like to inform you again that we are supposed to understand the development of these organs. I hope you did, and describe the anatomical locations of the liver, biliary, pancreas, spleen, identify the structures, including its blood supply, and learn some common lesions. So wrap up of previous lecture, I mentioned about the liver, its gross appearance, the ligaments, the surfaces, the lobes, the segments, blood surfaces. Liver, the blood supply. You know, what's this? So this is the same as the anterior coronary ligament, as this one. Anterior and in front of the liver, both of them, and they become falciform ligament. All right. So these are just peritoneal reflections. We discussed about the spleen, the gross appearance, the location, the blood supply. Do you agree that it is the largest visceral organ in the abdomen? Yes, no? The largest organ is the liver, in the abdomen, not the spleen. Spleen is located at the right lower quadrant. Wrong again. So it's located at the left upper quadrant, left hypochondrium. It's just a wrap-up plan. I'll give you a summary. Portal circulation. Do you remember portal circulation? Ito yung mga venous drainage coming from the stomach, from the spleen, from the pancreas, from the large intestine, from small intestine. The venous drainage all goes to the liver. So the portal circulation, this is the portal circulation, portal vein, portal circulation. It goes to the liver, and it goes to the hepatic veins to the systemic inferior vena cava. Pero pag barado siya, nag-accumulate yung blood inside the peritoneal cavity, inside the portal circulation, and what will happen? Mamaga ang mga ugat nito. That's why if you have distended veins within your portal circulation, you know the hydrostatic pressure, no? Pag malakas ang pressure within the vessels, there is the tendency that the fluid will seep out. There will be transudation somehow. So that's why there's ascites, Dahil yung spleen is very vascular, nagkakaroon ng splenomegaly. Naalala niyo pa yung anastomosis umbilical? Distended vessels becomes, we have this caput medusa. Etc. The structure parts, triangle of Calot, and you know the parts of the gallbladder. There's the cystic duct. The cystic duct is straight. No, it is S-shaped. Goes down, will penetrate the pancreas. The CBD will penetrate the pancreas, and the joint will be joined by the pancreatic duct of Wiersong, the major duct of the pancreas. And it will be joined together in what we call the hepatopancreatic ampulla. So I haven't discussed this. I haven't discussed yet the ampulla of Vater. So this is now the lecture of the ampulla of Vater, just to give you an idea. The ampulla of Vater is also known as the hepato. That means coming from the liver, and pancreatic, coming from the pancreas. Pancreatic ampulla is the ampulla of Vater, or hepatopancreatic duct. Somehow there's a duct there. And this is formed by the union of the pancreatic duct and the common bile duct. The ampulla of Vater is located along the second part of the duodenum. And this is the anatomical transition from foregut. I mentioned foregut, mouth, to the first half of the duodenum. That's a foregut. So this is the transition from duodenum and down, small intestine, rest of small intestine. Transition from foregut to mid-gut, and hence the point where the celiac trunk, do you remember celiac? And this is the area that the celiac artery stops supplying the foregut, and the superior mesenteric artery takes over pababa. So itong ampulla, no? Any fluid passing through here from the liver, from the pancreatic duct, is controlled by a sphincter. So meron din itong sphincter. So we call that sphincter of Oddi. So the outlet of each duct is protected by complex sphincter. There are about 4. That's just to give you a summary, just to give you an idea na from the CBD, meron niyang sphincter. Passing through will not be passing to the can you hear me?
Medyo
Okay
choppy
ba?
lang daw
Naririnig
po.
ko. Oh, nag-choppy ako. Oh my. Wait, I have to check my internet again. wala ako. Ito na. Connected. Connected na. Diba ginamit ko ito sa ikan? Microphone test. How's my signal? Mic test.
Okay naman po, Doc.
Thank you, thank you. Sensya na.
Okay lang po, Doc.
Mic test again. Ay,
Okay na po, Doc.
Ito, kita nyo na?
Yes
Pasensya na.
po.
Yes, Doc.
Okay. Ang sinabi ko, no, yung sphincter body, the complex no controls the flow of the bile going through the ampulla, coming from CBD, and there's also sphincter coming from the pancreatic duct, and somehow there's a coordination there para it will allow flow into the duodenum. This one. All right. So that's the sphincter body. There are variation actually for sphincter of body, just like the biliary tree. There's such thing as a common channel. There's no sphincter, but gallstone pancreatitis is very common in this case. And there is a partial common channel. Also, if there's a common channel, if there's a backflow of bile towards the pancreas, it will cause pancreatitis. And there's a separation naman. So, guys, let's go to the clinical correlation. I want you to understand this gallbladder again, extrahepatic bile ducts. This is a gallbladder. You can see the cystic duct. It's actually S-shaped, and there's those valves of Heister. This is the Hartmann's pouch located in the infundibulum of the gallbladder. Now, clinical implication. There are times that you may have the gallstones, stones in the gallbladder, but you won't feel anything. Bale ito, nagiging floating stones inside the gallbladder. Because of the dynamism of the gallbladder, it contracts during digestion. When you eat, there's fat, it contracts. Somehow it is acted by hormonal. And the stones also travels. It's okay naman if it doesn't go to the cystic duct. But if it goes to the cystic duct, and that will cause pain if the stone passes here. But there are cases that stones would still be lodged in the cystic duct and may be impacted there. This is due to the presence of these valves of Heister. And the valves of Heister actually keeps the stone from flowing. Dito pa lang, it will stop. But there are cases that following impaction, somehow these valves of Heister will be obliterated. And because of the obliteration, the stone will pass through. It will go there. And once it goes there, it's not anymore stopped by the spiral valves here. Medyo lumuluwang na siya. And once it's obliterated, patients who have passed one stone lang tend to pass more stones over the subsequent months. Dadaan at dadaan ng mga stones. Lalo na pag stone former ang pasyente. If you eat a lot of meat, fatty tissue, fatty foods, you're diabetic, you're very prone to gallstone formation. Ito yung delikado if it will keep on formation of the stone here, And then it will form again, form, until it is lodged in the ampulla of water. So what happens if there is an obstruction of the ampulla of water? Anyway, let's go first to the gallstone. Normally it's thin, no? But if there are stones, the stone will irritate the wall of the gallbladder. Once it is irritated, it will be inflamed. Once inflamed, the whole wall will be somehow infected. So the tendency, the pain-sensitive structures here, now you will feel right upper quadrant pain. And the pain is steady because of the inflammation. Usually it will occur 1 to 6 hours. And because of the developing infection, you have fever and chills. If you have fever and chills, what happens? You have tachycardia, increased heart rate. And because of the discomfort of the right upper quadrant, and somehow your respiration will also be affected. Dahil the up and down of your liver will also move your gallbladder. So there's some pain. So your respiration will be abnormal. Since this is part of the GIT, you will have nausea and vomiting because of the pain-sensitive structures at the outer part of the gallbladder, and it might be touching already the anterior abdominal wall. You know, the parietal peritoneum is very sensitive, so you have direct tenderness to where the inflammation is located. So we know the gallbladder is located at the right upper quadrant, so there is a right upper quadrant tenderness. Are you familiar with Murphy's sign? So I'll just give you an idea. Murphy's sign. So just think about a patient lying down on the bed, on a bed in a supine position, nakatihaya siya. And the abdomen is exposed, and you put your hands, the palmar aspect of at least 3 fingers, the distal tip of your the 3 phalanges, palmar aspect of your fingers is touched at the right subcostal area. Gentle, pushing downward gentle with normal respiration. And just by pressing that right subcostal area. And then you instruct the patient to breathe deeply. If you breathe deeply, that means you contract your diaphragm. Inhale, breathe deeply. What will happen to the diaphragm? It goes down. And it goes down also of your liver. Once your liver goes down, together with the gallbladder goes down, and pagbaba ng gallbladder, andyan yung nakapress yung kamay natin with your palpation. Nakadiin siya continuously. Once pag inhale niya, the gallbladder somehow will touch the already pressing hand, and because of the pain, the patient will stop breathing because of the pain. Parang pag inhale niya, biglang nag-stop ang breathing because of the tenderness of the pain. That's Murphy's sign. So that area will be tender also. There will be jaundice, abnormal liver enzymes. You will understand soon what is SGPT, SGOT, alkaline phosphatase. There will be elevated bilirubin levels. So what is the best diagnostic in identifying the gallbladder stone and inflammation? It's the ultrasound. Okay, ultrasound is the first line diagnostic method in bile duct without contraindication. This is non-invasive. 95% accurate. Right? So, ito, andito yung gallstone. Ito yung stone na medyo naipit na sa cystic duct. Masakit ito. This is very, very painful. And once the stone passes through the cystic duct, it will lodge on the CBD, and there will be no more bile passing through towards the duodenum. And the bile will go back, as I mentioned before. And what will happen? The bile goes into the system, and you will have a marked jaundice, even marked than just an ordinary gallstone formation. If you have a CBD obstruction, have a marked jaundice, you will have very high liver enzymes, you have a markedly elevated bilirubin levels. So if the stone here is impacted in the ampulla, and even to the point of having a stone stopping the flow of pancreatic. Tingnan natin na. Pag gallstone stops the bile and pancreatic fluid, there will be backflow of bile and pancreatic fluid going back to the liver, and the pancreatic fluid going back to the pancreas. If there is a high pressure in the pancreas, somehow the acinar cells are injured, and once it is injured, the cells mismo will release some protease or some proteins, and these proteins can activate the enzymes in pancreas, and enzymes can digest tissue of the pancreas. Oops, I have to discuss pala the pancreas. So what is pancreas? Pancreas it resembles a letter J, no? Or a curved-handled cane. So it weighs around 80 to 170 grams. The head lies at the duodenal side here. The 30% of pancreatic size is underneath the curve of the duodenum. And the body and tail, about 70% of its size, slants obliquely, going up to the left across the abdomen. And tip of the tail abuts against the spleen. The uncinate process here, no, kasi J siya, comes off from the side of the pancreatic head. So functionally, it is a gland both endocrine and digestive exocrine function. Pero yung exocrine naman, 80 to 90% of pancreas functions the exocrine. So only 10 to 20% endocrine. The endocrine is the one that secretes insulin, glucagon, somatostatin, and other pancreatic proenzymes to help regulate the sugar and other metabolism of the body. The main pancreatic duct, this is the main pancreatic duct, is the duct of Wirsung. So the duct of Wirsung drains most of the pancreas, and there is such thing as an accessory duct. Santorini, this very small one, only drains a very small portion of pancreas. So this one, just to give you an idea, the pancreas, from here, this is the head, and this is the neck, and this one is the uncinate process, and this is the body, and the tail. Okay? For the anatomical relations, again, this is your pancreas, this is S shape. Again, the head lies within the concavity of the duodenum, kanina nakita natin. And somehow the head here corresponds to the body of the lumbar, second lumbar of the vertebra. And mapansin mo yung head is just anterior to the inferior vena cava. Nalalam nyo ba yung foramina epiploica? The epiploic foramen? Okay, this is the uncinate process. Mapapansin nyo, the portal vein and the superior mesenteric vein is behind the pancreatic head or neck. But once it goes down, the superior vein and the pancreatic and the portal vein is anterior to the uncinate process. Bale, yung curve ng pancreas, yung head, and the uncinate process goes behind of this superior mesenteric vein and portal vein. Again, the tip of the pancreatic tail extends up to the splenic hilum. And di ba I mentioned the celiac trunk, celiac artery? This is the celiac trunk or celiac artery. This gives off the major blood supply for your stomach, spleen, liver, and pancreas. So itong celiac trunk or celiac artery gives off the splenic artery, the left gastric artery, and common hepatic artery. Tatlo ito. So mapapansin nyo, the splenic artery, that supplies your spleen, goes above. The celiac trunk lies at the upper border of the pancreas. And once it branches off the splenic artery, it runs the upper border of the pancreas, of the body of the pancreas, the upper border, tortuously, and goes towards to its tail and eventually to the spleen. So this is the anatomic relationship of other organs with the pancreas. Another drawing here is the pancreas. Look at the uncinate, it is behind the portal vein and superior mesenteric vein. Pero at the neck, it is anterior to its location of the inferior vena cava. So the head again lies within the concavity of the duodenum. The head corresponds to the L2, lumbar 2. The tip of the pancreas abuts the spleen. And that's the celiac artery. It gives off to left gastric artery, the splenic artery, tortoise just above the border of the pancreas, and the common hepatic artery. This gives off, the celiac artery gives off most of the blood supply of the upper GI. Where's the triangle of Calot? Calot. The triangle of Calot. So there, that's the triangle of Calot. The triangle of Calot, medially the wall is made of a common hepatic duct. Laterally, it is the cystic duct, and above it, superiorly, is the edge of the liver. Significance here is the presence of cystic artery inside the triangle of Calot. Calot. So blood supply of pancreas, Again, this is the celiac trunk or celiac artery. It gives off the splenic artery, and there is also the left gastric. There should be left gastric artery here and the common hepatic artery. So remember, by the way, pancreas is a very, very rich blood supply. There are good surgeons who can remove the pancreas. I haven't seen removal of pancreas here in Tacloban, but in Manila and Cebu, they're very good in removing this. This is a very bloody procedure because it has a rich blood supply from the celiac artery. So typically in 90% of people, the celiac axis divides what I've mentioned, common hepatic, left gastric, and splenic artery. The common hepatic artery dito, mapapansin nyo, bababa siya and will give supply to gastroduodenal artery. And the gastroduodenal artery will go below the first portion of the duodenum, and it will divide and becomes the posterior, becomes the pancreatico-duodenal artery. So the pancreatico-duodenal artery divides to anterior and posterior pancreatico-duodenal artery. So as it divides the superior part of the duodenum and pancreas, anterior and posterior, it forms an arcade and link with the branch of, this is superior here and this one is inferior. It forms an arcade and link with the inferior pancreatico-duodenal arteries. And this is the branch of superior mesenteric artery. Di ba na-mention ko, this part, this is the junction. This is the area where you have the ampulla vater. This is the junction between the mid of the duodenum, mid of second portion of the duodenum. This marks the end of the supply of the celiac artery here. And the rest will now be supplied by the superior mesenteric, hindi na sa celiac trunk. Ito yung marks also the transition between the foregut and the midgut, the small bowel, the rest of the small bowel. So these two vessels form an arcade, so they really supply very well the head of the pancreas. So the body and the tail is being supplied by the splenic artery, and we have the dorsal pancreatic artery. It goes down, goes below the pancreas, goes to the parenchyma of the body and tail of the pancreas. And there is a network of vessel that connects from the splenic artery and the dorsal pancreatic artery, coming from the transverse pancreatic artery also. Note the vascular supply of the pancreas. And why is it vascular? Because it has also an endocrine function. So the venous drainage of the pancreas, tingnan mo na hinati natin ang pancreas dito para makita natin ang likod. Makita natin ang portal vein, makita natin superior mesenteric vein sa likod. Andito yung splenic vein. So, napapansin din, somehow, if there is an arcade of splenic artery, the artery arcade of the superior pancreatico-duodenal artery, there's the inferior pancreatico-duodenal artery, and likewise, in the same manner, there's also the same, an equivalent for the veins, superior pancreatico-duodenal vein and the inferior pancreatico-duodenal vein. Both of them drains into the superior mesenteric vein. So this comprises the venous drainage of the pancreas. Just imagine, no, the portal vein. I mean the portal circulation. Portal circulation. This is portal vein receives the big splenic vein, and this big splenic vein, it has its tributaries. The inferior mesenteric vein. Your inferior mesenteric vein drains most of the large intestine. Splenic vein joins with superior mesenteric vein to become portal vein. The superior mesenteric vein drains the venous blood coming from the rest of the small intestine. The appendix area, the ileum, the jejunum, and the distal part of the duodenum. This is the portal drainage. Just to give you an idea also, there are variation of different pancreatic ducts. Ito yung normal, duct of Santorini, diretso siya, meron siyang connection. And this is the duct of Wiersum and the Ampulla. 60 to 70% occurs, but there are others, variation, 30% of that. Yung duct of Santorini, hindi yan dumidiretso sa duodenum, medyo blunted siya. Although meron naman siya connection, but blunt, there's no connection to the pancreas. So these are the variations of the pancreatic ducts. Accessory duct is absent, part of the 30% suppression of accessory duct. And in very, very rare case, but it occurs in 10%, wala siyang Wiersum. So the Santorini is the major duct that drains the whole pancreas. So clinical correlation. So may I ask the class, anong tawag ng inflamed liver? May mag-answer ba nito? Inflamed liver?
Hepatitis.
Inflamed gallbladder? Yes?
Cystitis.
Pwede. Medyo pitin lang.
Cholecystitis. Cholecystitis.
Cholecystitis. Tama. Stones in the gallbladder?
Cholelithiasis.
Yes.
Cholecystitis.
Yes. Cholelithiasis or cholecystolithiasis. Pwede silang dalawa. Stones in the common bile duct?
Choledocholithiasis.
Correct. Thank you, Ms. Kantapay. Choledocholithiasis. Inflamed pancreas, ura-ura pining.
Pancreatitis.
Okay, nauna si Chris. Thank you, Chris. What do you mean by CT scan? CT.
Computerized tomography.
Yeah. Chorus, galing niya. MRI.
Magnetic resonance imaging.
Okay. TRCP.
Endoscopic retrograde cholangiopancreatography.
All right. Yes. Thank you. So, at least you know, no, clinical correlation of pancreatitis, no. Nearly 70% of them caused by cholelithiasis, alcoholism, and even ERCP, yung sinabi, endoscopic retrograde cholangiopancreatography, can also injure the pancreas. In some cases, nakakatakot din. Kaso this is one way to remove also stone nga impacted sa ampulla. Trauma, na aksidente, na blunt trauma sa tiyan. Post-operative, it can happen somehow. Tumor. The serum amylase levels rises within few hours once merong damage ng pancreas. This is very sensitive but not specific. Why did I say not specific? Sensitive siya, talagang tataas siya. Hindi sensitive, hindi specific kasi it will even happen to any perforation of the stomach due to ulcer. It can happen to ulcer perforation, mesenteric infarction, tataas ang amylase natin. Torsion of yung mga volvulus can increase amylase. Trauma, mabunggo ka, nagkaroon ka ng hematoma sa likod ng tiyan, retroperitoneal hematoma will also increase serum amylase. Ectopic pregnancy. Meron. Do you understand ectopic pregnancy? Anything outside your uterus. And so forth. No? Renal failure, salivary gland inflammation, it increases amylase levels. So these are important, the pancreatic function tests to determine the pancreatitis. So ultrasound is one of the effective to identify swelling, but it's not sensitive. The most sensitive is CT scan and MRI. So if there are stones, ERCP is one of the good diagnostic tests to check the level where the stones are. X-ray is important, chest and upper GI series. What is GI?
Gastrointestinal series.
Yes. Thanks, gastrointestinal series. May mga iba hindi nakakaintindi what is CT, MRI, so I have to be sure to make sure that you know all this. So ito na yun ha. Remember yung gallstone in the ampulla, once may obstruction dito, babalik yung pancreas, enzymes. No, example, no? Meron tayong stone dito, it will stop the flow of the bile and pancreas. And what if it stops the flow? And siyempre, it backflows. Bumabalik yung mga bile and pancreatic. So mag-accumulate yung fluid dito. Ganon din sa bile doon. Papunta sa liver, mag-accumulate. And since we're specific to pancreas, there is increased ductal pressure dito. And the ductal pressure can injure the very sensitive acinar cells ng pancreas, the one that produces the proenzymes. And once meron dyan, once there is an injury, and the injury will release intracellular somehow some proteins, and this can activate your enzymes. Just to give you an idea again, yung nasisecrete na fluid galing sa pancreas are proenzymes. They are not yet activated. They will only be activated by the presence of trypsins here or hormones to activate the proenzymes, and they become active and they can help digest the food. Pag may obstruction, the injuries mismo, the injury of the acinar cells can release proteins and it can activate the enzymes. And once it activates the enzymes, what will happen? The enzymes can digest the pancreas. So namamaga ito. Even to the point that they will leak. They will cause leakage sa labas ng pancreas and can worsen pancreatic injury, and the leak enzymes can digest the omentum, fatty tissue. Nagkakaroon ng saponification din. Naluluto yung taba sa intraperitoneal cavity. So ito medyo nakakatakot ang pancreatitis. Okay guys, summary. Were we able to describe the anatomical locations of the different organs mentioned? I hope you were able to understand them, identify also and describe them. I hope you know their roles and learn some clinical correlations. So, ang review portion natin, liver. So, tanong ko, is it the largest organ of the body?
Largest visceral.
Liver. Visceral organ.
Visceral.
Largest visceral.
Largest visceral organ.
Yes. Largest organ intraperitoneally or largest visceral organ. Anong largest organ in the body?
Skin po, Doc.
Skin.
Skin.
Yes. Skin. Tama. Dami nag-answer. So, liver is located at the where?
Upper right.
Right,
Upper right.
Yeah. Yes, right. Hypochondrium din. So, dalawa yan. More or less, they're the same. And they're completely covered by peritoneum. True or false? Yes. We know the bare area, di ba?
Yes.
And it is completely covered by the Gleason's capsule. True or false? True. Yes.
True
Hindi
po.
to lalabas kasi alam nyo eh. Joke lang. So, do you remember the origin of the round ligament? It is the remnant of portal vein. No. Umbilical vein.
Ligamentum teres.
Yes. That's ligamentum teres. Umbilical vein. Yung ligamentum venosum. Remnant of
Ductus venosus.
yeah, ductus. Ductus. Basta venosum, venosus. Yan na lang tip. Basta maintindihan. Pang board exam yan. So that ligament actually is connected to the inferior vena cava. So dapat alam natin na caudate lobe, falciform, what divides the lobes. At least these are just example. Portal circulation, dapat alam natin. In portal circulation ba, meron bang cardiomegaly? Kasi may splenomegaly, hepatomegaly, meron bang cardiomegaly? Malayo yun eh, di ba? Abdomen ito, wala sa heart. So these are just example. Esophageal bleeding, that's portal circulation. Di ba may esophageal varices? Yung kapanahunan namin, maraming namamatay na pasyente dahil sa cysto. The schistosomiasis causes fibrosis ng liver. Once may fibrosis ng liver, so nagkakaroon ng portal hypertension kaya lumalaki ang liver dahil distended ang mga vessels, pati yung spleen malaki. Kasing laki pa ng jar. Meron pa nga yatang malaki ng one half gallon na bote. So ito nag-bleed. Nagkakaroon siya ng upper GI bleeding due to bleeding of the esophageal varices. Noon yun. Pero because of the effective treatment against cysto, medyo konti na lang. Pero wala nang namamatay. Pasalamat tayo sa Diyos sa mga gamot ngayon. Spleen. Spleen is rounded. Dapat alam natin ang shape. Hindi siya rounded. Madali siya mapalpate. Hindi siya madali mapalpate. Gallbladder. Alam natin kung anong gallbladder. Yung triangle of Calot is located sa inguinal area. Hindi nasa liver siya. Diba yung Hasselbalch's triangle. So these are just example. Just want you to know. By the way, what do you mean by cholangio? Cholangio. You've heard about endoscopic retrograde cholangio. Cholangio is the biliary tree. All right, anything the biliary tree, cholangio, kung meron siyang infection ng biliary tree dahil may stone, nag-infection, there's such thing as cholangitis. You will encounter this. Naintindihan niyo na ba kahit konti?
Yes, Doc.
Okay, just would like to share if you want to become more powerful in life, educate yourself, if you want to learn, be determined, no one can stop you. If you want and strive for progress and always change towards good, not perfect, just better. And seek God always, kahit masakit, and lalo na kung masaya, thanking Him always. Okay, guys, thank you and thank you. God bless you. God bless your exams, future. Hope you become, every one of you will become my colleague. So that ends my report. Thank you, thank you.
Thank you, Doc.
Doc.
Thank you, Doc.
Thank you.
Thank you, Doc.
Thank you, Doc.
Thank you po, Doc.
Ingat kayo lahat.
Thank you, Doc.
Thank you.